NEI Spring Congress is headed to my home of Florida, May 1st through 3rd, and I hope you'll join me. Come for the latest in psychopharmacology. Stay connected with like-minded clinicians and experts. Walk away with the tools that make a real difference in clinical care. Registration is open now, and spots are filling fast. Use code NEIPOD26. That's all capitalized NEIPOD26. Register now at nei.global/spring.
Welcome to the NEI Podcast. On this show, psychiatrist, psychopharmacologist, and chief medical officer of NEI, Dr. Andrew Cutler, sits with renowned mental health experts from a range of backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions.
Welcome back to our myth-busting series. Today, we're taking on one of the most misunderstood medication classes in psychiatry, that's antipsychotics. And I'm joined today by my good friend, Dr. Jonathan Meyer, to sort through these myths from questions about brain effects and safety to how these medications support recovery and function. Hello and welcome, Jonathan.
Hi, Andy. It's wonderful to be here. Wonderful to talk about antipsychotics. Or I think they're not always antipsychotics, are they?
That's really funny you say that, because how is it that a medicine called an antipsychotic can do things other than treating psychosis?
Well, to be honest, if we were having this discussion 50 years ago, it would have been psychosis and maybe acute mania. But as the indications have broadened significantly for unipolar depression, bipolar depression, autism, all sorts of things, the confusion, I think, in the public's mind is that they hear a drug called an antipsychotic and they think it's its only mechanism of action. And therefore, if my clinician is suggesting that for my bipolar disorder, I must have some severe illness beyond bipolar disorder.
Yeah, I think we have to recommend to our audience, to our clinicians, that you have to hit this head on right at the beginning. If you're going to prescribe one of these medicines for something other than a psychotic disorder, you kind of have to hit this head on, don't you?
I think so. And I think a big part of it is talking about the nuanced uses of these medicines. Yes, the initial indication for this class was for psychosis, typically for adults living with schizophrenia. But for one thing, we use them very differently, often in different dosages when we're using them for other indications such as mood disorders. And therefore, the tolerability and adverse effect profile may also be somewhat different.
That is true. You know, our friend Stephen Stahl likes to say DD, DD, different drug at a different dose. And so that's a good point you're making there. We know that there's a lot of stigma around our illnesses to begin with. But how does the stigma around antipsychotic influence people's attitudes, both patients and clinicians?
A couple of things. Certainly when you're using it outside of the scope of schizophrenia, for example, people may infer, as I said before, this means something about their illness, or infer maybe they have the wrong diagnosis and they have schizophrenia. That's a point of education. I think also beyond that, there's the impression that these must be powerful medicines and they're going to have a certain level of harm or safety concerns. And even when we're using them within the world of schizophrenia, I think sometimes folks, including ourselves, focus too much on the adverse effects of the medicine itself. But certainly within the world of schizophrenia, we have to talk about the harms of untreated psychosis. Yes. That is itself disease modifying. When people have relapses, they lose not only friends, family, jobs, but drug responsiveness. And the risk-benefit equation has to include also the harms that accrue for people who are inadequately treated, really regardless of the diagnosis.
Well, I love you're saying that, because a lot of times when we think of risk-benefit, when we're talking about risk, we focus too much on side effects of the medicine. We don't talk about the risk of inadequately treating the illness. I think that's true for mood disorders and other disorders we're going to use these medicines for as well. There's a lot of misconceptions about how antipsychotics work, and even if they do work. So how do we think these things work, and what do we know about how they can affect things beyond symptoms such as recovery and so on?
For schizophrenia, the class of medicines, which we call antipsychotics, largely work via the dopamine D2 receptor, interfering with dopamine signaling. There are special medicines like clozapine, which likely have other activities and work for a subset of people who we call treatment resistant. If we confine the discussion just for now to schizophrenia, we think the idea is that by mitigating the excessive dopamine signaling, if you're not treatment resistant, we can reduce the severity of positive symptoms. That is the core mechanism. A lot of the other aspects of these molecules in many instances are unwanted. Earliest antipsychotic was chlorpromazine, or as we know out there in the world, thorazine. It was very sedating. We've come to appreciate that sedation is not an antipsychotic mechanism. It is a completely unwanted aspect of the molecule, which we've tried to eliminate with successive generations of these medicines. Some of the motor side effects we've also tried to minimize as much as we can with successive generations of medications. And as we now perhaps practice in a different era in the 21st century, if I'm treating an individual living with schizophrenia, I don't want to sedate them. I want them to have all of the cognitive abilities which they now have even with their illness. And that's why there's literature out there about the use of benzodiazepines in schizophrenia, that they don't make you smarter and they actually increase rates of mortality. Sedation is not what we want. It was just an unfortunate aspect of some of the molecules. But in terms of function, the point is that if you have a severe illness like schizophrenia, you don't function optimally, typically if your positive symptoms are not well controlled. And regardless of the concerns about safety and tolerability of these medicines, they actually improve function, they decrease rates of rehospitalization, and they keep people alive. That mortality is actually reduced in individuals who remain on antipsychotics, even ones which out of the box seem like they have a lot of side effects like clozapine.
Well, you may be referring to the famous meta-analysis by T. Honan and others that I remember when that came out, Jonathan, was a little surprising to us because we were so concerned with weight gain and metabolics. But what T. Honan found was, no, you actually decrease all-cause mortality, including cardiovascular death, kind of paradoxically, I guess.
Well, when people are more optimally treated, they're better able to participate in all aspects of life, including their non-psychiatric medical care.
Well said. Jonathan, don't you think also successive generations of these medicines, the hope was not only to improve safety and tolerability, but maybe to address broader symptoms beyond just positive symptoms? The hope was maybe to help negative symptoms in cognition and mood.
That was the hope. I can say unequivocally that adding serotonin 2A antagonism to a D2 blocker definitely mitigated its motor side effects. There's no question. Lower rates of TD, lower rates of drug-induced Parkinsonism or akathisia. Notice I didn't use that three-letter acronym. I think it begins with an E and ends with an S. I don't know what the middle letter is. But there's no question. However, recent meta-analyses have indicated that we haven't made great strides for the D2 binding agents on mitigating negative symptoms or improving cognition. Now that has changed now that we're in the era of the muscarinic agonist antipsychotics. And as you probably know, there is some evidence from their pivotal trials that there might be an impact on negative symptoms, which is not, as we say, pseudo-specific, meaning it might be a more direct effect, and also on cognition.
Definitely. I would argue, Jonathan, though, that while all antipsychotics are antipsychotic, they're not all antidepressant. And so I believe that adding other receptors to D2 blockade, some of those receptors may have antidepressant effects. Here we know some of these medicines are especially effective for certain mood disorders such as bipolar or unipolar depression. So certainly adding other receptors is not only adding side effects, if you will. Receptors are not inherently good or bad. They're sort of double-edged swords. You know, you can get side effects, but you might also get benefit.
I think that's important when we talk about the uses outside of schizophrenia, especially for the depressive disorders. We're fortunate that in this day and age, we have now multiple agents indicated for bipolar depression, both 1 and now bipolar 2 in the way that we didn't before. And that is due to the fact that these molecules have these other properties which confer antidepressant actions, some of which work independently by themselves, like lumateperone, cariprazine, lurasidone, quetiapine. Others work adjunctively with an antidepressant, such as aripiprazole. So this is an important part of it. And I think the idea is as we apply these in different areas, we have to acknowledge both what the benefits are and what the unique pharmacology is that attributes to taking care of that particular problem.
As a matter of fact, we can't avoid antipsychotics when we're talking about mood disorders, Jonathan, because there's only 5 drugs FDA approved for bipolar depression, and all 5 of them are atypical antipsychotics. There's only 4 FDA approved as of today for adjunct for MDD. They're all atypicals. We're about to get a 5th one approved, lumateperone, and then we'll have 5 in each category. So that's true. Let's address another stigmatizing label, if you will, besides just the term antipsychotic. The original term for these medicines was neuroleptics, which I hate it probably as much as EPS, to be honest with you, because it sounds like you're doing bad things to neurons. And I think this led to some of the early worries that you'd be causing brain damage, especially longer term.
So there's a couple of things that come from seizing the neuron, which is what neuroleptic meant. Back in the day, these agents were very strong D2 blockers, and people sometimes would complain of emotional blunting. And we can see this even when we're using them for mood disorders. There are some people who are very sensitive to D2 blockade. I think it's important as you use these medicines to try to look and see what is exactly going on. Is the patient complaining of emotional blunting from excessive dopamine blockade? Or is this in fact a sedating aspect of the molecule when it is a sedating molecule? This is often not as difficult as we think, because we know which medicines are sedating and which medicines are not sedating. The other concern, though, as you allude to, was that the first-generation agents in particular might have some inherent neurotoxic properties and cause loss of gray matter over time. There were some animal studies which looked at this, but as we've now moved into the era of prospective trials, where we can follow people from the onset of the illness and disentangle disease effects from drug effects, we have a sense that these medicines broadly do not cause unique harms on brain matter. And most importantly, the biggest disease effect is actually not the drug, but the disease.
Well said. I mean, this is, of course, a neurodegenerative illness when we're talking about schizophrenia. Mood disorders also untreated may be to some degree neurodegenerative, damaging to the brain. And so here again, we have to talk about the risk of inadequately treating the illness. The illness itself is damaging to the brain. The other thing, of course, you and I are big fans of is talking about be careful about adjunctive anticholinergic use, which can also impair cognition.
Yeah, I do want to give people a reference just to look up. So you may have all heard of a Stephen Stahl. He wrote a paper in 2022. The first author's name is Fountoulakis, Fountoulakis. It summarizes the prospective imaging studies looking at changes in brain matter and antipsychotic use. And I think it gives us the best answer to the question, should I use a first-generation agent if the patient needs a D2 blockade? And I think the answer is yes. Untreated psychosis is much worse than anything the medicines might do, and there's not great evidence for an independent medicine-related effect.
As a matter of fact, there is some evidence that some of our newer agents may, in fact, be neuroprotective in some ways.
I think we could say, as much as possible, keeping people free from psychosis is the best way to preserve their brain. I can say unequivocally, if we're talking about schizophrenia, you preserve drug responsiveness. But you alluded to bipolar disorder. We've come to appreciate if you're bipolar 1, you will have 3 times higher rates of dementia than your age-matched peers. And what's the biggest contributor to that, disease-related? It's manic episodes.
I always think of that as like a storm in the brain somehow, which is obviously not a good thing. I had a professor years ago, Jonathan, 30 years ago when I trained, before we had some of the neuroimaging studies, who said, never let anybody stay psychotic because psychosis is bad for the brain. And I think we haven't changed our thinking about that, have we?
Absolutely. And I think the point is that, and again, I'll confine my discussion just to schizophrenia, you have to give the brain what it needs. If it needs a bit more D2 blockade, you should not be afraid to do it if that's what they need. And we have some long-term studies, one of the best of which is a study which compared haloperidol decanoate to paliperidone palmitate. And a couple of things. Haloperidol is a potent medicine. You have to use it gingerly. We now understand better from studies like the Katie schizophrenia trial, modest doses are the way to go. But over the 6 months of this study, guess what? People on modest dose of haloperidol decanoate did just as well in terms of symptoms. But who had less weight gain?
Haloperidol.
Who had less prolactin increase?
Haloperidol, surprisingly.
Absolutely. There was a modest difference in the rates of akathisia, but the differences were modest, and that's because the haloperidol was dosed modestly.
Well said. So dosing is critical, of course, to all of these medicines. There's another misperception about, especially I guess when we're talking bipolar, that you'd be blunting the personality. How do you sort that out? If it's the illness, the medication, other things, over sedation?
D2 blockade bums people out. I think that's a fair statement. It doesn't mean they'll be depressed, but they may complain of some cognitive impairment. And so you do have to spend some time figuring out what were things like before you started the atypical. Was there a dose-dependent effect where maybe I've overshot and we can back off? As much as possible, we like to eliminate sedating and anticholinergic medications for all human beings, not just those living for schizophrenia. Please try to eliminate agents which have central anticholinergic activity. As I said before, and I think you would agree, benzodiazepines don't make you smarter. I understand a lot of people who've been recently manic get sent out of the hospital and a whole bunch of stuff, including hefty doses of clonazepam. But these are things which need to be eliminated as much as possible. Could it be the molecule? Yes. The partial agonists tend to induce less of some of this than do the antagonist, and that's something to factor in as you try to manage the problem.
You bring up another important point, and that is the difference between acute treatment and maintenance treatment or longer-term treatment. Sometimes we have to use these adjunctive medications, such as a benzodiazepine, let's say, or something else. Sometimes we have to use higher doses to control an acute psychosis or mania. But over time, I don't think we should set it and forget it. We need to dynamically reevaluate the choice of medicine and the dose.
There's a whole literature out there on deprescribing. You've lectured about this. It's very important to understand that over time, some people may do well with lower exposure to medication. You, of course, have to proceed much more gingerly if you're treating an individual whose working diagnosis is schizophrenia. But for one thing, occasionally we are wrong. And that's why there's a small fraction of people who had an initial diagnosis of schizophrenia who can actually be weaned off of medications. It's likely they didn't. It may have been more of a substance-induced or mood disorder-related psychosis. But I think it's important to recognize that maybe the dose that they were sent out on isn't the dose they have to live with the rest of their life.
You know, in my experience, Jonathan, and you've seen this too, doing a lot of consultation in the California state system, is people tend to add medicines but rarely take them off. And so that's how we inherit these patients who are on these cocktails of multiple medications. So I think it's very important to continually be reevaluating that.
With reference to bipolar disorder, I think I will recognize that we only have so many options available to treat bipolar depression. As a point of education, among the FDA-approved agents for acute bipolar depression, which does not include lamotrigine, which is for maintenance, they all work by different mechanisms. Lurasidone is serotonin 7.
5-HT7 probably.
Yeah, cariprazine is
D3 and 5-HT2B.
Quetiapine.
Well, what's interesting there is there was a mystery for a while. We didn't fully understand what was going on until we identified an active metabolite, norquetiapine, which is a very potent norepinephrine reuptake inhibitor. But also, Jonathan, I recently reviewed this. It has high affinity for 5-HT2B as well, which we've learned more recently is a real antidepressant mechanism, increases release of serotonin, for instance.
And then lastly, we have lumateperone, which has its own interesting mechanisms, including facilitation of glutamate neurotransmission via D1 modulation. That being said, one mechanism may not be sufficient, just like unipolar depression. If you have somebody on lurasidone and they have partial response, they may need another agent. Now, if you want to add lamotrigine at that point, that's fine. But don't assume that you're doing something bad or wrong if you have somebody on lumateperone and lurasidone. They may need those complementary mechanisms to manage their bipolar depression.
Well, we have to acknowledge the obvious fact that these are heterogeneous illnesses, both clinically and neurobiologically. And so you're right that there's no one mechanism is going to work for everybody. Unfortunately, as you well know, we don't have a good biomarker, a blood test, or an X-ray to guide this treatment. Sometimes there's a little bit of trial and error involved, and we have to find the right combination very often. But that's okay. That doesn't mean our medicines don't work, or we don't have any idea how they work, or it's just all voodoo science, right?
No, I agree. And I think the biggest part, which we're talking about here, is you have to talk with your patients about what your thinking is, why I think you have this diagnosis, why this medicine is appropriate, why I'm using it maybe in a different way than I would for its original indication, which might have been for schizophrenia. And then we go over some of the tolerability and safety issues which are known to that medicine, but also eliciting from them what their concerns are.
Yeah, that's really well said. And sometimes a helpful way I frame it, especially when we're talking about bipolar depression, is you have a different kind of depression that requires a different kind of treatment. Because unfortunately, just like antipsychotics are called antipsychotic, antidepressants are called antidepressant, but they don't work for all depression, as we've said.
Yeah, I think, education is so important. If you want to use, for example, an adjunctive atypical for unipolar depression, you have to acknowledge there is a small risk of tardive dyskinesia. Don't be afraid to talk about it. They may have seen ads on TV about medicines to treat TD. They may have heard it. Explain what it is. Explain the risk, which is very small, how we will together manage that risk. But most importantly, that you feel, given their stage of the illness, the benefits outweigh the risks. If the patient says, well, I don't want to take those medicines at all you can say is, maybe you'll reconsider over time. We can look at other strategies, but I think this still might be a useful tool. And please, let's think about it in the future if the other strategies don't work out.
I really like what you're saying, Jonathan, because sometimes I think we feel the need to close the deal the first time we bring it up. Like, you need to take this now. I think sometimes we're starting a discussion. And especially when we're using shared decision-making and taking the patient's preferences and goals into account, I think it starts a little bit of a longer-term discussion that ultimately might lead to a change in the medication.
I mean, sometimes people will say, I don't want any medicine that has weight gain associated with it. All I can say to that is, you really are tying my hands and trying to get you to be the best version of yourself, which I think this is why you're here. And we have medicines with different risks for weight gain. We will always start with the medicine which has the lowest risk, but there is some risk, and I don't want to minimize that. And you will decide with me together if you think this is something you want to try, especially if other things don't work out the way we hoped.
I think you're right, and I think it would be ideal if we could choose our medicines just based on efficacy, but unfortunately, on average, they all seem to work. But we all know for individual patients, one's going to work better than the other. But what is very clear and can help guide our decision-making are the side effect and safety profiles. And sometimes I don't know that we investigate with the patient what side effects may be more or less troubling to them, because that could certainly guide my choice.
Absolutely. There's a reason we call it shared decision-making. You have to get their perspective. Now, again, their perspective may be somewhat extreme. I don't want a medicine which has any of these types of side effects. Well, then we will use what we can, which fits within this paradigm, but at some point we may exhaust this very quickly, and then it'll be your decision.
I think it's also important to allow the patients to realize that we have a plan in place here. Okay, we're going to try this. If this doesn't work or is intolerable, we have other options and we can go on to that. So we don't want them to get frustrated or give up too soon in the process. When we're talking about the safety and tolerability, however, and I realize, as you said, there are legitimate concerns here, of course, but it's important for us to do true informed consent. So how can we help our clinician friends to have those discussions around the potential risks?
For one thing, acknowledge them. If you're going to use something which binds to the D2 receptor, there is a risk of movement disorders, typically akathisia, Parkinsonism, or tardive dyskinesia. Don't minimize that. You should know that the rates are very, very small. You should have a plan for managing that risk. One thing, justify your logic also of why you think this type of medicine can be helpful at their stage of the illness. But patients deserve to hear the word tardive dyskinesia. And if they say, oh no, absolutely not, I think all you can say is, look, here's the risk, here's how I manage it with other people. And if that's your decision now, we will work with what we can, but we may have to revisit this. The same with the other types of adverse effects. And put it in perspective. For example, I work a lot with people in what we call a first episode program. It's not only schizophrenia, it's bipolar 1. Because of their age, they are very sensitive to weight gain. We don't tell them anything other than the fact we're going to pick the medicines, at least early on, which have the most benign profile with respect to weight gain. But because of who they are, they're more sensitive than other people, and we will do what we can to try to mitigate that.
Well, I like the term mitigate, Jonathan, because we can never really fully eliminate risks, but we want to try to mitigate them. We want to tell the patient we have a plan. And ideally, if you are open and honest and start that discussion, they'll be more likely to share that with you at the first sign there's something going on. which gives us an opportunity to intervene and ideally keep them on the medicine. Because again, I think what has to guide this discussion is, what is the risk of inadequately treating the illness?
The best way you can get anyone to cooperate with treatment is, I think, to respect their intelligence, acknowledge their thoughts, even if you're coming at it from different angles, at least if they think you're trying hard to do what's best for them, you're not being paternalistic and tell them you should take this or X, Y, and Z will happen. Yes, I appreciate if somebody says, I don't want an adjunctive atypical that may limit me in treating their bipolar depression. I'll use what I can. It's not a lot, but I'll use what I can. But at least I'll say, we'll give it a go. And then if we run into problems, we don't get the efficacy, let's talk again about the subject.
I think it's most important to use evidence-based medicines. Unfortunately, in psychiatry, that's not often done. And so even though an evidence-based medicine may engender more risk, such as the fact that the only drugs that are evidence-based for bipolar depression are antipsychotics, atypicals, I still think we have to start with the evidence base, right?
Absolutely. And I hate to say it, sometimes we're not always really good at practicing evidence-based medicine. Sometimes people use medicines which are easiest for them to prescribe and avoid using the only medicine that might work for the disorder. And the poster child of that in this context is clozapine for treatment-resistant schizophrenia. There's strong evidence for its use. It's grossly underutilized. And I think the problem is you do have some people, sadly, who say, I wasn't trained to use it, therefore I won't. But what message is that giving to the patient? That I'm either going to suggest a medicine which has no evidence for resistant schizophrenia, or I will overestimate the concerns around clozapine while minimizing the benefits. If you have treatment-resistant schizophrenia, we don't have evidence that anything else is going to work. And per our earlier discussion, it has benefits in saving people's lives. Yeah, what's one of the indications besides resistant schizophrenia? It's
suicidality. Suicide prevention.
That's it. And that's one of the things we've noticed, that when people are deprived of clozapine, they have high rates of suicide. When people are taken off of clozapine in that first year, very high rates of mortality, mostly due to suicide. It keeps people alive. In this day and age, in the United States in particular, almost nobody dies from severe neutropenia because we monitor it. Yes, there's no more REMS and you're responsible, but we're very good at monitoring. And I think the most important statement I can make is, you can learn how to prescribe clozapine, even if you didn't in your training. If you're working with people with schizophrenia, you really have a moral duty to learn how to do it, and you can do it. I think everyone listening to this podcast who is a clinician likely has the ability to learn how to prescribe clozapine. There's resources out there, and your patient's brain really needs it.
You know, I wouldn't necessarily shame everybody, though. Even if you are not comfortable yourself, don't you think it's important to have a referral source to at least be able to get the patient to the medicine, even if you yourself aren't the one prescribing it? Is that reasonable?
I think that's a very fair statement. I feel like people sometimes feel overwhelmed and they're not quite ready, which I understand, but then you want to have somebody you can get them to immediately.
You know, there is also this notion, first of all, Jonathan, I hate this conceptualization of first generation, second generation. I think that's just too blunt a division. But there is a misperception, let's say, that the newer medications are automatically safer than the first ones. How accurate is that, and how should that guide our selection?
Yeah, I alluded to this before. We certainly appreciate that the high-potency older medicines did have higher rates of drug-induced movement disorders. See, I didn't use that three-letter acronym. And there's no question, adding serotonin 2A antagonism or using a partial agonist, your rates of all drug-induced movement disorders are probably 3 to 4-fold lower, including tardive dyskinesia. But except for clozapine for resistant schizophrenia, the newer agents are not more effective. Even the new muscarinic agonist, xanomeline trospium, when you look at the meta-analyses, and specifically meta-analyses which use the meta-analysis statistical method, show that it's not more effective than what we've had for the past 30 years. It's right in line with what we've had from olanzapine, or maybe a little bit better than risperidone. Obviously, its tolerability profile was very different, and that's one of the wonderful things about it. You don't have the risk for weight gain or movement disorders or endocrine dysfunction. But there is a role for using modest doses sometimes of first-generation agents. You know, the Katie schizophrenia trial showed that pirfenidone was not necessarily inferior to the other agents in terms of overall tolerability. It actually had somewhat less weight gain, as I mentioned from that one study by Joe McAvoy that was published in 2014, compared to paliperidone palmitate. Haloperidol decanoate had less prolactin increases. These are useful tools. You just have to know how to use them and use them wisely.
Yeah. Well, if we think about the early second-generation drugs, I can't say first-generation, second-generations, but if we think of, for instance, clozapine, risperidone, olanzapine, quetiapine, we didn't inherently realize initially about the weight and metabolic risks, but we were very excited they had less movement disorder risk. But then we started to realize that they had a significant risk of weight and metabolics, which means they were not necessarily safer. But I think over time, as we've had newer agents introduced, we tend to see much less risk of weight gain and metabolics, which is encouraging.
Improving tolerability, we think, does improve the outcome of keeping people on drug. But we do know that people cycle through medicines for a variety of reasons, sometimes inadequate response, sometimes tolerability, and we have to accept that. But to be honest, we really have improved dramatically on overall efficacy in the world of schizophrenia with the newer agents, but we've improved dramatically in tolerability. I will make one caveat, though, that the muscarinic agonist xanomeline, we think, as we talked to before, may have some unique benefits on negative symptoms and maybe on cognition in a way that we didn't have from the D2 binding agents.
No, I think that's true. And I think, again, though, when we're talking about meta-analyses, we're talking about averages. And so on average, these drugs are similarly effective. But again, we know for an individual patient, some may do markedly better with one than another. We just don't know who they are. And so that may be true with the muscarinic agents as well. Let's move on and talk a little bit about long-acting injectables, because there's certainly a lot of misperceptions out there about this. Certainly, I was trained 30 years ago when we didn't have second-generation long-acting injectables, and we were sort of taught that you had to earn your LAI by being bad or being non-compliant or by relapsing. And there's still some kind of conception around that today. How can we address that?
I think now that we have a broader array of long-acting injectables, and we've had the appreciation that relapse in schizophrenia in particular diminishes drug responsiveness, including all the other life disruptions that happen with relapse, that we should be offering people an LAI as early on in the course of their illness, literally from day one, for two reasons. From our perspective as clinicians, I want to preserve the brain that this person has. I want them to preserve the level of function they have. And the best way we can do this is by keeping people adherent on medications. But again, from the patient's perspective, maybe they just like the convenience of an LAI. I think sometimes we forget because we were educated, oh, it's for a bad person, they were stigmatized. But there's ads on TV for LAI forms of HIV medications, obviously for hormonal contraception. Why do people like them? Because they're convenient. I think you and I have talked. If there was an LAI antihypertensive, we might. Why not? I don't have to take a pill every day. And how can somebody agree to an LAI if it's never offered to them?
Yeah. See, I agree. I think it's almost irresponsible to not offer all of the options. Certainly if we had a family member who had cancer, God forbid, and you went to the oncologist and you found out they were not offering you all of the evidence-based chemotherapy treatments, I think we'd be pretty unhappy with that.
Absolutely. And it's very sad when I hear about somebody who's been ill for 3 to 5 years. They come in sometimes with their family, and literally they've never been offered an LAI option. Our use of LAIs is actually at historic highs in the world of schizophrenia in the United States. It's roughly maybe 15% of the antipsychotic prescriptions, but we want it to be higher. We want people to start it earlier on. It's the best tool we have for mitigating relapse. But you know, there's another group of people who benefit from long-acting injectables, and that's people with
bipolar disorder.
Bipolar 1,
yeah.
Yes.
Yeah, because we know that recently the subcutaneous version of risperidone has gotten FDA approval for that. And then can I tell you a quick story, Jonathan? So I was an investigator on the first study of risperidone microspheres for bipolar 1, and I thought, oh my God, it's going to be hard to recruit for these patients. What patient with bipolar is going to want an LAI? I was shocked. It was actually not hard at all. It was simply me having the discussion with the patient and offering this as an alternative.
Well, again, how can people with bipolar 1 disorder agree to an LAI if it's never offered to them? I think sometimes as psychiatric professionals, because our predominant use has been for individuals living with schizophrenia, we think, oh, this person is not psychotic. How would they ever say yes? Or why would they say yes to an LAI? So we're projecting our own prejudices. But guess what? These people are inherently non-adherent, or they like the convenience of an LAI. Whatever the reason, if you never offer to them, how can they say yes? And now that we have an easier to use option of risperidone, because the only other LAI form of risperidone that was approved for bipolar 1 was
the risperidone microspheres, which unfortunately is every 2 weeks as opposed to every month or every 2 months.
And it was intramuscular. And now we have a subcutaneous form of risperidone, easy to administer, small volumes, can be delivered in the back of the arm. And we have the long-acting injectable forms of aripiprazole monohydrate 1 and 2 month, which are also indicated for bipolar 1 disorder. You have a couple of options, different molecules, different attributes, different delivery systems. Your patient needs to hear about both. They may prefer one or the other, but they can never vote for either of them if they're never offered.
That's 100% right. And I sometimes say, Jonathan, that we should not make the decision for the patient. If you don't offer it, you're deciding for the patient. And I think that's irresponsible.
It's an illness, especially when you have mania involved, that can be very life disruptive. I mean, mania destroys lives. People end up in the hospital, they spend all their money, their relationships are dissolved because of all sorts of behaviors. And as I mentioned, being manic is not good for your brain. It's not good for your long-term cognition. Our use of LAIs in bipolar 1 in the United States is under 1%. And we're hoping now that we have a subcutaneous form of risperidone approved for bipolar 1 disorder, that conversation, if it never happened before, can happen now. Or if it did happen in the mists of the past, it can be revisited and people can be offered the opportunity to have something. The value of these agents is mitigating manic relapse. But again, that's often the most disrupting aspect of the disorder acutely.
Well, Jonathan, depression is also not good for the brain. We have abundant evidence that more episodes of depression lead to scarring and damage to the brain and irreversible cognitive impairment. And it kind of occurs to me, we're very comfortable offering LAIs of atypical antipsychotics to patients with schizophrenia. Why shouldn't we be comfortable offering an LAI version of a drug that we use all the time for bipolar?
It's our own prejudices. I think that's what it is, because we only thought, oh, it's a schizophrenia medicine. Well, it's not. And now that we have another form, I'm hoping you out there, the listeners who are clinicians who see individuals living with bipolar 1 disorder, will have the discussion with them, let them know about options. You might be surprised, as Andy said, when he was doing the trials way back in the day, risperidone microspheres, who might be saying yes.
No, I was very surprised, Jonathan, and it really led to a change in my thinking of which medicines to offer and how I treat people and so on. There's another stigma or misperception around LAIs, and that is that they are seen as coercion. And that comes from the fact that our short-acting injectables are used in a situation where someone is out of control and it's maybe given against their advice or their consent. How do we address the coercive sort of discussion?
Again, this is part of shared decision-making. If I'm working with any individual, I'm trying to figure out, what are your goals for treatment? Why are you even here in this office? We often think if somebody comes in who has, for example, schizophrenia, it's, oh, I don't want to have voices. Often that's not what they're thinking. Their thinking is, I want to have a relationship. I want to have some type of job, volunteer or otherwise. I'd like to reconnect with my family. Well, what are the tools I have that can help you with this? And this is one of the best tools I have to help you achieve your functional goals. If they're bipolar 1, they may have a different perspective. But the idea is that these are tools which can help people reach their goals. In some instances, they are the most effective tool, the most effective technology we have to get them to their outcome. It's their choice. Unless there's an involuntary med order, there's a court order, it should be part of a shared decision-making. And the only thing I will say is it shouldn't be a one-and-done conversation.
I couldn't agree more, Jonathan. I think it is a process and it's an ongoing conversation. I like how you frame that. I think also the fact now that we have subcutaneous LAI options, and excitingly, Jonathan, you and I are involved with the development of a subcutaneous olanzapine preparation. Now that changes this thinking of coercion and deep needle, big needle, and all of this. So I'm hoping that more subcutaneous options will also lead to more acceptance, if you will.
Convenience. Sometimes we don't even think about that. Oh, the patient might like it because it's more convenient. Again, among the individuals with their first episode of schizophrenia, sometimes they like the LAI because they don't have to take a pill every day, which is not only convenient, but it doesn't remind them every day of this illness that they never wanted because they have to take a pill. And I just can't minimize how valuable that is for a lot of people.
Well, you may have heard me tell the story before. One of the first patients I was recruiting for an LAI study, when I was sort of awkwardly having this discussion of, oh, do you want to take this medicine as a shot, blah, blah, blah. And he lit up when I talked about not having to take a pill every day. And I said, why is that so important? He said, taking a pill every day is a daily reminder that I'm crazy. And he literally said that, and boy, did that open my eyes and change my thinking. So you're right. It's not only about the negatives of these drugs. We should lead with some of the positives, some of the potential benefits. Decreasing relapse, helping you achieve your goals, convenience. I think those are all important things.
The ads for HIV LAIs talk about freedom. Who are these people? These are the highest functioning people. They don't bother taking pills. They get their shots and they go about their lives. And I think when you present it as, a lot of my patients really like the freedom of getting these medicines as an injection. And it could be injection every 1 month, every 2 months, sometimes even longer.
Yeah, there's longer ones now. 3 months and 6 months even. Well, as we get closer to wrapping up here, Jonathan, some people assume that all antipsychotics are interchangeable or that once you start with one, you have to stay with that one. How should we think about individualizing the choice, the duration, the dosing, and so on?
Well, of course, number one, it depends on what the indication is. If I'm treating somebody adjunctively for unipolar depression, there's certainly an ongoing discussion of if the adjunctive strategy gets you better, is that something you have to stay on forever? Maybe, maybe not. And I think that should be a discussion with the patient. I want them to be in remission, both by symptoms as well as by function. And once they have been in remission for a period of time, we can talk about, do you want to try peeling this back? Do you want to see how you can do on a different strategy? That's fine. For bipolar depression, we have less options. If everyone can remain stable on the motrigine, that would be wonderful, but that's not often the case. And I think that will be a different type of discussion. In the world of schizophrenia, though, I think the big debate is, do they need to be on the dose they need to be on? And even, do they need to be on medicines at all? I think the literature is strongly in favor of the fact that if you really have a diagnosis of schizophrenia, there's high diagnostic stability. Meaning if I see you a decade later, there's probably more than 90-something% chance I have the correct diagnosis. And that people removed from antipsychotic medications completely may not do well, to say the least. That being said, when you have new agents which come out, like the muscarinic agonist, and I have somebody who is adherent with oral therapy, well, I think that's an important discussion. Do you want to try this new option? Look at some of the upsides for this. Yes, there may be some other issues in instituting it, but you have to keep abreast of what the new options are out there because they may be very appealing to the person you're seeing in front of you.
Well, I couldn't agree more, Jonathan. And we have to, of course, be cognizant of the reality that access, cost, insurance, payers often dictate our treatment decisions to some degree. But why wouldn't you want to consider a muscarinic agent early in the illness and not have the risk of tardive dyskinesia in particular, weight gain, metabolic disturbance, possibly having more benefit for cognition earlier in the illness when you have more cognition to lose?
Absolutely. The only aspect, which is a realistic clinical concern, is can the patient be adherent with oral medication? I think it's reasonable to offer to people. I think it's important to assess the individual in front of you. If you think, realistically it's not possible, that's fine. That's a strong recommendation for LAI early. But that's not true for a lot of people living with schizophrenia. And boy, look at those upsides.
It, of course, will be wonderful, and I think you are a big advocate of potentially one of these muscarinic agents being eventually developed into an LAI, and that'll be a whole different discussion as well. Well, Jonathan, we're coming to the end of the time. Time always passes quickly when we talk, and I really enjoyed this, and I hope it's been helpful for our audience. But as we wrap up, what are some of your key takeaway points here? What are some of your final messages to our audience?
I think we appreciate across all of the disorders where antipsychotics, as we call them, are commonly used, that undertreatment accrues harms to patients. And yes, medications do have adverse effects, but optimally treating somebody knowing how to use all the tools, knowing how to use them wisely with appropriate dosing, gives people the best option they have for achieving their functional outcomes.
I love what you said. I think also we need to raise the bar a little bit on our expectations. Merely keeping somebody out of the hospital, to me, is not a good enough goal. Why shouldn't we want a patient with schizophrenia to have what we would all have, which is some meaningful relationship, something meaningful and productive to do, for instance? So I feel like we should not be satisfied or settle for good enough is good enough. We have more tools now, and we do need to individualize, to some degree, our choice of medicines. Well, Jonathan, thank you so much for your time. Thanks for joining me.
Been a pleasure to be here, Andy, and I hope you out there have enjoyed this conversation.
Yes. Thank you all for listening, and for more information about our other podcasts and our other NEI educational offerings, products, and services, please check out our website, neiglobal.com. Thanks for listening.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit neiglobal.com.